So, Dr. Calam, I'd love to ask you some questions about these two publications that you've published, both to do with qualitative health research, which is quite a, back then it was actually quite a feat to actually publish qualitative health research in CMAJ. So tell us about what led you to your work in the North. And how, as a clinician, did you get your toe into research?
I guess the journey north was an epic journey. It was a kind of a full circle, having been born in northern BC, even though I left there when I was quite young and actually did part of my growing up in inner city in Manhattan. I felt this pull to come back to the Pacific Northwest and a real sense of after my medical training and my internship and a little bit of extra training to go out into rural and remote medicine, I felt this sense of adventure and wanting to go out there and raise a family and become a strong clinician. And so that was a big part of the arrival in the North, was working in locums ever further westward and northward and finding myself in Haida Gwaii with a position there in Queen Charlotte City, and learning the ropes of being a full-service family physician. And so once I kind of got my feet on the ground there, and that took a few years, including having children and starting to raise young ones, I was able to start to think beyond the immediate clinical questions and the immediate having to be on my feet in terms of emergencies and hospital care and all of that. And I started to ask myself some questions about what I was doing. And my aha moment, I think, started when I was quite frustrated one Friday afternoon when I had been doing PAPs all day as one of the few female family physicians working in rural remote at that time. And I decided I wanted to understand if I was over-screening people, because I couldn't imagine that there were that many PAPs to do in such a tiny town. And so I started to ask myself some questions, and that led to that kind of crystallization into a research question, which is, am I screening appropriately? Am I screening the right women? And that led me to a chart audit.
So tell us about the chart audit. What did you find?
Well, the chart audit was a manual audit, which was really fun and a bit frustrating, because when I'd completed my audit, I realized there's one question that I'd forgotten to ask, so I went back in there and re-pulled all the charts and did that again. But it showed that there was in spite of there being identical screening services available in the community, there was a big discrepancy between Haida and non-Haida women in terms of their screening rate, particularly for the older Haida women. And that did surprise me because of the identical services that were available in the community. And it led me to wondering what could we do to improve the lower screening rate for the Haida women and maintain the good screening rate for the non-Haida women. And so that was my aha moment about moving from quantitative, which I had done, to thinking about how do I find out what I should do next. And that led me into asking the women who were affected by this question about, PAP screening and what it meant to them, and what were the barriers and what were the facilitators to them actually participating in screening, and what could we do to redesign screening in the community to meet their interests and their needs, and give them the the sort of the power to design this and evaluate it.
So maybe you could just tell us about that study that you published in the Canadian Family Physician, where you actually reported on this study. Tell us about the insights that you learned from that, and tell us what you did and what the women told you.
Well, it was wonderful. I mean, the first step for me was to go to the community health representatives at the time, who were women that I had worked with clinically for a number of years and developed a relationship with around clinical care. And these were community health representatives who lived and worked in Skidegate. And their advice to me was to ask the women who were involved. And so they said, why don't we go and find out from them what they think about A, what we should do with this data that we have, and B, what we should do from there. And so they actually went sort of door to door and in informal ways and just said to people, influential people in the community, and said, what do you think Dr. Calam should do? And they said...
So that was your key informant interview.
Well, that was actually not. That was kind of like just the lead up to the preliminary part of it. And they came back to me and they said, well, a lot of the elder women here are saying that you should publish your results around the chart audit, and you should work with them to help design a better PAP screening. And so then we did it formally, and we got our ethical approval, and we did interviews with the women, and then we took their advice and designed this PAP screening clinic that was going to happen in Skidegate. And we took very seriously and carefully the specific information they gave us about making the PAP screening experience more comfortable and more culturally safe for Haida women. And that included, you can see in the paper, there's a number of specifics like, have female physicians, don't use paper gowns, use cloth gowns, and many things like that for comfort and for supporting people to feel comfortable in their own space. And so we did that. And we certainly didn't reach everybody who was eligible for screening, but we were able to increase the screening rate significantly compared to what it had been before. And so we also did some interviews, exit interviews of the women about what their experience was like. And so that pre-intervention interviews and then the exit interviews were my first experience with stories and with phrases and with text and with paragraphs, which I then studied very, very carefully and tried to understand what were some of the general themes that were coming out of that. So that was my first I didn't really think of it as qualitative, but it was at the time.
And what were the challenges that you experienced doing that work?
I think at the time they were more structural. I mean, I was a busy family physician doing 1 in 3 call and delivering babies and flying into remote, communities and logging camps and that kind of thing. So time and doing the sort of the project off the side of my desk is not part of the regular clinical care. That was challenging, but it had its own inherent reward in it, in that once we did it and I realized that the PAP screening rate had improved, including women who'd never had PAPs before attending, and understanding their reasons for doing that was there was some inherent reward in that busyness. Yeah.
It's amazing. So then tell me now about your second project. Tell us what led you to the second project. What was the clinical background that led you to the second project?
So fast forward to leaving Haida Gwaii. I guess that would have been a decade after the first, the PAP screening study. I took on the position of medical director of the family practice ward at St. Paul's Hospital, which is a ward where family doctors admit their own patients and family practice residents and medical students work with them. And one of the things that was like a burr under my saddle was noticing that when asked by nurses or family members, has anyone established code status with this patient? More often than not, the answer was no, and there were some questions as to, what is a reasonable amount of time before a patient who's been admitted to hospital should have a code status established. And so I spent some time sort of reviewing the literature and realizing that this was a big problem across, certainly across the country and across the continent and probably across the world, that there are delays in finding out what people's end-of-life wishes actually are. And so I spent quite a bit of time immersed in the literature around that, understanding, there are scales that will help you decide whether a person would benefit from resuscitation or not, and trying to get a feel for that. So again, I did a chart audit, and again, it was a paper audit, but this time I was smarter, and I got all my questions ahead of time, and I didn't have to go back and get the data. And it did show that less than half of the people who would have been considered by these scales to not be likely to benefit from resuscitation, less than half of them had a clarified DNR order or a code status order in the first week of admission, which astonished me.
That's
again,
yes.
Because these are patients admitted by their own family doctors, followed by their own family doctors in a wonderful team where there's it's an interprofessional team, and there's a lot of discussion that goes along. So I wanted to get a feel for what's going on, at least least from the resident, the learners and the family physician's perspective. And so it seemed to me that a qualitative inquiry of what is your experience of establishing code status with patients like on a teaching ward, on a family practice teaching ward. So that led to, the question, and then it seemed, I consulted with a qualitative researcher to figure out what would be the best method of doing this, and we decided to do in-depth interviews, and then we did a grounded theory analysis of it. And for me, having that consultant was really helpful. It was like having a statistician with a quantitative project, and that person walked me through how to go about doing this. And it was a revelation. I couldn't tear myself away from the stories, the narratives, including distressing stories of learners and physicians recounting when they were medical students, how they were often pushed to the front and made to have the conversation with the patient when they might not know them as well as perhaps the doctors, or having the family physicians feeling that there were many conflicting influences, in their hearts as they were trying to approach a beloved patient, and whether or not raising the topic now would erode the trust that the patient had in them, or whether it would cause harm. And so the stories were very poignant to me, and I learned a lot about analysis. And one of the challenges was the time it takes to do qualitative analysis in a good way, and how trying to sort out the themes. I did it in the old highlight and cut the phrases and the themes out on the kitchen table, actually up in Haida Gwaii. And one day the wind blew through and rearranged my entire scheme. So nowadays we would do it on a software program, but that was a real. It was so enriching for me to hear what people said, and then to try to build some themes, including things that would help and things that hindered the having those conversations with patients, and then subsequently using that information to design an educational intervention for residents to help them with the conversation, and to have that as now part of our curriculum at St. Paul's. So. Yeah, it was very rewarding.
And it's a phenomenal study published in CMAJ in 2000. I'm sure that was one of the first qualitative health research projects to be published in CMAJ.
I'm not sure. There weren't a lot, I can tell you that. And I think that I don't know if it was the right place at the right time. There was a lot of focus on end of life and DNR at the time. But again, scanning the literature, there was really very little about what were the experiences of family physicians who undertook the care of their patients, and what would happen when those patients showed up in hospital. Again, that astonished me, because we are generally the people who almost everybody turns to when it comes to having that code status discussion. So it was part of the challenge was getting the manuscript ready for publication, and to whittle down this fantastically complex and marvelous narrative into the format that you'll see in this paper. But it was a good experience of trying to distill what the messages were without losing the narrative quality of it.
It's a beautiful paper.
Yeah.
So thank you. And tell us how these projects informed your later work, and where are you now with qualitative research?
Well, I think that what I love about qualitative research is that it gets at human experience. It gets at the meaning people make of their experiences, and how they make that meaning through or with the sort of cultural, contextual aspects of their lives. And I think what draws me to primary care and the comprehensive care and the sort of the whole person is what draws me to the qualitative research. But you can see in both of these that the learnings I have subsequently turned into interventions, and so what I'm learning to do is to think about how to apply this into improving the health experiences or health status of people. But the other thing is the process, and specifically with the first project, the sense of participating with or learning with rather than doing research on. And so I've been very drawn to that relational, collaborative, ethical research that is not just grounded in Western ways of thinking or Western ways of knowing. So I'm drawn towards Indigenous concepts of how what knowledge is and how you generate knowledge, how you pass knowledge on. And I'm very drawn to the idea of Indigenous methodologies from around the world. And so I'm quite excited about that, reading as much as I can. There's a concept called Indigenous métissage, a paper by Dwayne Donald that I'm just reading right now. I'm just halfway through it now, and I'm very excited about that. The idea of how do I broaden my understanding of how to inquire in a good way. So that's informing work that I'm doing with Skidegate around cultural safety, around Haida concepts of health and wellness. And then there's an international study, and the Canadian part of it is a CIHR-funded study looking at how do we design an educational intervention that comes from qualitative inquiry with Aboriginal patients with diabetes and their physicians. How do we design an educational intervention that might help to improve the care experience of Aboriginal people or Indigenous people with diabetes, and that's in the intervention design phase now. But we'll evaluate the intervention with input from Indigenous patients about what their experience of care was with people who've had or not had the intervention. So that's kind of exciting. It's
that
big,
is,
and it's informed by people's stories, which have been carefully collected and analyzed, not only not only sort of with us as a team, but with them in a participatory way.
Fascinating. Thank you so much for taking the time to be interviewed today. We
You're
really
very
appreciate
welcome.
it. Thank you very much.
Okay.